I am Dr. Debarati, Bhar, endocrinologist from Kolkata. Today we are discussing a case about patients of diabetes who have a higher risk of hypoglycemia. This is a very common problem which as endocrinologists, as doctors, we encounter when patients come to our clinic. We will give an exemplary case today. A 50-year-old lady, she's a known case of type 2 diabetes. She came to me with the complaint that she had been suffering from recurrent episodes of hypoglycemia. Most of her glucose readings were between 50 to 60, and she had experienced the severe symptoms of having palpitation, sweating. For the last 2 months, she is a known diabetic patient. For the last 10 years, she is on these two common drugs we often use in our day-to-day practice, that is metformin. In a dose of 1 gram, she was receiving twice daily, and a sulfonylurea, like say glimepiride, 2 milligrams twice daily. And her lab findings and physical examination revealed a BMI. Obviously, in Indian population is somewhat high, 31 kgs. She has a normal blood pressure of 120 by 70, and her pulse is good. HbA1c is on the higher side, as you can guess, 8.2. Cholesterol and other lipid profile is otherwise normal. Her liver values of LFT are normal. Creatinine in this age group is slightly high, 1.1, which is common for a 50-year-old lady, and the GFR comes to around 65 ml. So what to do now? Now, obviously, the glycemic control is the most important problem, and the weight management issue is another problem. But together with this, we have a problem of hypoglycemia, which is preventing us to advance our treatment by increasing the further dose of sulfonylureas. Now, the HbA1c at this age, appropriate goal should be around 7% or less, and 6.5 should not be targeted in this age group. So, as we all know, India has a bad name of getting the capital of diabetes as well as the capital of obesity, and all our third world countries are suffering from healthcare infrastructure problem together with the burgeoning epidemic of diabetes. So, a typical history of long-standing diabetes, a typical history of recurrent hypoglycemia, which prevents acceleration of other drugs. We need to get a drug which will have a good effect on renal profile, a good effect on her weight loss, as well as no further added risk of hypoglycemia. So sulfonylureas obviously have to be decreased. So which agent to use? We have a strong rationale for combining two new drugs in the market. They have been in the market for a long time. The DPP4 inhibitor, which enhances our endogenous GLP-1 and thereby reduces our blood glucose levels effectively from the pancreas, but does not have any hypoglycemic effect. Another very good drug which all our guidelines recommend and has definite cardiorenal protection is the sodium glucose transport inhibitors, SGLT2. And these drugs are very much effective in also lowering blood glucose without causing any hypoglycemia together with weight loss. And we all know that all patients who are taking SGLT2 inhibitors have some rebound increase in glucagon, and hence in this elderly age group a risk of euglycemic ketoacidosis. But this effect can be blunted up by lowering the glucagon level, and lowering glucagon level by acting on the alpha cell. Only one drug of this class has its effect orally, and that is the DPP4 inhibitors. So this rational combination of these two drugs will be an effective management option for glycemic status in this patient. HbA1c lowering we can achieve from 8.2 to 7 by using these two drugs, and a weight management issue we can add. Additionally, when added over metformin and stopping the sulfonylurea, we can get a weight reduction at least 1.5 to 2 kgs. And even the American Diabetes Association recommends that an initial combination therapy is very much effective when the HbA1c is above target, and an oral drug is the best insurance of compliance of this patient. So this unique combination tends to the glycemic profile of the patient, does not cause any great burden on the patient because we have combination therapies available now, does not increase the risk of hypoglycemia, safely omitting the sulfonylurea in this case, and does not cause weight gain, rather it induces weight loss when added to metformin. So a combination therapy of SGLT2 inhibitors with DPP4 inhibitors is the choice of drug in this patient group. And also reducing genital infections. It has been seen that elderly people with genital infection are lesser when SGLT2 is combined with metformin or DPP4 inhibitor. also possibly because of a better glucose control. So please go on using these safe drugs, and thank you for this hearing.